Hello, my name is Cupid Graves and I'm the Clinical Education Specialist for Banner Boswell. In this session we're going to cover the cardiopulmonary system. These are the objectives we will accomplish as we talk about the cardiopulmonary system. Describe the primary function of the cardiopulmonary system and associated diagnostic studies. Identify correct assessment of presenting symptoms and appropriate nursing interventions associated with the cardiopulmonary system. And finally, review core measures associated with the cardiac and respiratory systems. The primary purpose of the respiratory system is to supply oxygen to the tissues through inspiration and eliminate carbon dioxide through expiration, or in other words, gas exchange through the transfer of O2 and CO2 between the atmosphere and the blood. The cardiovascular system complements this action by transporting oxygenated blood to tissues and removing waste products. This actually becomes the driver of the human body. The two systems work hand in hand to maintain homeostasis. What affects one affects the other. The cardiovascular system consists of the heart, blood vessels, and supporting veins. The heart is a four-chambered pump, two atria, two ventricles that circulate blood to the lungs and throughout the body. The left ventricle pumps oxygenated blood to the body, high pressure. The right ventricle pumps unoxygenated blood to the lungs, low pressure. Arteries deliver oxygenated blood from the left ventricle to the tissues, and veins return unoxygenated blood to the right side of the heart. Each heartbeat or cardiac cycle consists of two phases: the systolic, which is the heart's contraction, and the diastolic. The ventricles relax and fill with blood. The volume of blood ejected from the left ventricle, the ejection fraction, will be discussed later in heart failure. Blood pressure is the force of the blood in a vessel. Systolic is the higher pressure, diastolic is the lower pressure. EF is measured in percent. Normal is about 50%. The heart can increase its cardiac output by 20% with exercise. The best measure of blood pressure is to have the patient sit quietly for 10 minutes in a chair with his or her arms at their side. The respiratory system is made up of two parts: the upper and lower respiratory tract. The upper tract includes the nose, pharynx, adenoids, tonsils, epiglottis, larynx, and trachea. The lower tract includes bronchi, bronchioles, alveolar ducts, and alveoli. Except for the right and left main stem bronchi, all lower airway structures are within the lungs. The right lung has 3 lobes, and the left lung has 2. The chest wall is also part of the respiratory system and includes ribs, pleura, and chest muscles. Common disorders that you may see on the units are hypertension, heart failure, acute coronary syndrome, valve and vascular disorders, pneumonia, influenza, adult respiratory distress syndrome, adult respiratory failure, pulmonary embolism, pulmonary edema, COPD, asthma, pleural effusion, pneumothorax, TB, and head, neck, and lung cancer. It's important to remember that a sustained high blood pressure will cause damage to the blood vessels. A one-time elevation is not considered high blood pressure. So management includes lifestyle changes and medications. Lifestyle changes include weight reduction, dietary approaches to stop hypertension. Eating plan includes rich in fruits and vegetables and low-fat dairy products with a reduced content of saturated and whole fat and whole grain foods. Regular daily exercise and physical activity is recommended. Limiting alcohol, stop smoking, and using relaxation techniques can also be effective. Medications that are prescribed are usually either an ARB or an ACE with a diuretic. The best control is usually obtained for most individuals with the use of two or more medications. Diuretics decrease blood pressure by facilitating excretion of water and sodium. ARBs prevent action of angiotensin II and produce vasodilatation and increased water and salt excretion. Angiotensin converting enzymes, otherwise known as an ACE, prevents the renin-angiotensin mechanism from acting on smooth muscle, and prevents vasoconstriction. Beta blockers interfere with transmission of substances which vasoconstrict and stimulate the heart. Calcium channel blockers decrease blood pressure by blocking calcium influx to the smooth muscle cells and promotes vasodilatation. If diabetic, the diabetic is usually started on an ACE inhibitor or an ARB to maintain renal function. Beta blockers are recommended for those with stable angina. These are some of the common diagnostic studies that you will see. Chest X-ray, whenever there's a concern for an enlarged heart or fluid around the heart. An EKG, which shows a graphic representation of electronic impulses. An echocardiogram, where ultrasound waves are used to check structure and function of the heart. An MRI provides images on multiple planes, showing cardiac tissue, aneurysms, etc. The treadmill is used to check the effect of exercise tolerance on myocardial function. The thallium scan is radiation isotopes are injected or inhaled by a patient. A scan is then performed to note areas of uptake. This is done at the peak of exercise, and you may know it as a stress test. It is used to diagnose coronary artery disease, DVT, renal function, cardiac EF, and more. The megascan, otherwise known as the multiple gated acquisition scan, is when a nuclear isotope is injected to the point of areas that may indicate myocardial blood flow. It is done after the last minute of exercise. Additional lab values that you might see are the troponin 1. Troponin 1, which is released only by the heart and not by skeletal muscles, is a more specific marker for MI than troponin T, which is done for internal injury. Troponin 2, a protein found in both skeletal and cardiac muscle, can be detected in the blood following heart injury, for example, external, maybe trauma. The CK, creatinine kinase, the normal value is less than 7 units per liter. It will rise at 48 hours after infarction, peak at 12 to 24 hours, then remain elevated for 72 hours. The CPK is an cardiac isoenzyme that is released specifically from damage to the heart. During your nursing assessment, what types of things are important when assessing the cardiopulmonary system? History. Ask about it. Has the patient had chest pain or radiation of pain to the arm, neck, jaw, or back? Also ask about atypical symptoms such as extreme fatigue, weakness, indigestion-like symptoms, nausea, vomiting, and shortness of breath, especially in women. Ask about any palpitations, dizziness, shortness of breath. When does it occur? Is it related to exercise or other activities, or at a certain time of day? Fluid restriction. Do they have to take their shoes off at the end of the day because they are too tight by day's end? Extreme fatigue. Can they do ADLs? Are they able to climb a set of stairs, 16 steps? How many steps do they walk in a day? Is there a presence of cough, wheezing, sputum production? Pay attention to the cough. How long has the patient had it? Are they at current or past smoking? Is there sputum production? Or is it a dry, hacking cough? Are they on an ACE inhibitor? Most important, can they speak more than 5 words before they need to take a breath? Ask about past medical history in terms of personal and family. Ask about lifestyle changes, lifestyle situations contributing to cardiopulmonary issues. Relating to the symptoms, when did they start? What makes them better or worse? In your inspection, you're looking at skin color, nail color, clubbing. Sputum, what color is it, and the characteristics. Dyspnea, the use of accessory muscles, symmetry of movement and retractions. In auscultation, you're listening to the rhythm of the heart. Any extra or funny sounds? A bruit over the abdominal artery usually indicates an aneurysm. Look at the pattern of breathing. For palpation, locate the auscultation sites. Apply gentle touch and pressure, noting pulse rate, rhythm, symmetry, and strength. For percussion, listen for hyperresonance or dullness of lung areas, percussive borders of the heart. Here are some basic facts about pneumonia. Pneumonia is an inflammation of the lungs caused by bacteria, virus, fungi, or parasites. Pneumonia is a particular concern if you're over the age of 65 or have a chronic illness or weak immune system. It can also occur in young, healthy people. Pneumonia can range in seriousness from mild to life-threatening. Pneumonia is often a complication of another condition, such as the flu. Antibiotics can treat most common forms of bacterial pneumonias, but anti-resistant strains are a growing problem. The populations most at risk are adults over 65, children less than 2, and the chronically ill. Additional risk factors include smoking, alcohol, chemicals, surgery, traumatic injury, and the artificial vent. Pneumonia often mimics the flu, beginning with a cough and a fever, so you may not realize you have a more serious condition. Symptoms can vary depending on your age and general health. The signs and symptoms of pneumonia may include fever, lower than normal body temperature in older people, cough, shortness of breath, sweating, shaking chills, chest pain that fluctuates with breathing, otherwise known as pleurisy, headache, muscle pain, and fatigue. These are the Joint Commission core measures for pneumonia and influenza. Every adult is screened for a pneumococcal vaccine and given if indicated. Blood cultures are ordered and done in the ED. Were they obtained prior to the first antibiotic dose? IV antibiotics must be given within 6 hours of hospital arrival. Oxygen assessment is important, and smoking education is important. The plan of care for pneumonia patients includes a multidisciplinary team effort, antibiotics as per core measure requirement, supportive therapy, hydration, medications including antipyretics, antitussives, and antihistamines nasal decongestants. Oxygen therapy is needed. Patient teaching related to understanding the risk and benefit of future events. A few additional strategies include good hand washing, pneumococcal vaccine, cough and deep breathe postoperative patients every 2 to 3 hours, and the incentive spirometer hourly while awake. The diseases that fall under COPD include asthma, emphysema, chronic bronchitis, and chronic obstructive bronchitis. Some common treatment strategies include avoidance of irritants, smoking cessation, bronchodilators, corticosteroids, supplemental oxygen, exercise, nutrition, and antibiotics and vaccinations. A collapsed lung occurs when air escapes from the lung and fills the space outside of the lung but inside the chest. It may be caused by a gunshot or knife wound to the chest, rib fractures, or certain medical procedures, or it may be spontaneous. In some cases, a collapsed lung occurs without any cause at all. This is called a spontaneous pneumothorax. A small area in the lung that is filled with air can burst open, sending air into the space around the lung. Common management may include, for a small pneumothorax, it may resolve on its own without much attention. Oxygen and rest are important. There may be placement of a chest tube into the pleural space. A chest x-ray is then done at periodic intervals, which will provide information related to lung expansion. Nursing measures include O2, cough and deep breathing, maintenance integrity of the chest tube system, frequent position changes, pain management, and dressing changes as ordered or needed. This is a picture of the OASIS system used at Banner facilities. You will review this at our stations. 2 words describe heart failure. Inadequate pump. The heart is too weak to pump blood to itself and for oxygen exchange. What is ejection fraction? It equals the stroke volume. Ejection fraction is the percent of blood ejected out of the ventricle. Normal EF is greater than 65%. With heart failure, EF is less than 45. The total capacity for each stroke is 140 milliliters to 184 milliliters. Presenting symptoms may include dyspnea. The patient is unable to speak more than 5 words at a time. They may appear pale, fatigued, and slightly cyanotic. They may present with decreased exercise tolerance, sudden weight gain, blood pressure, heart rate, and respiratory fluctuations, and pulmonary edema. There may be decreased urine output. There's a frequent dry, hacking cough, but clarify whether the patient is on an ACE inhibitor. The patient may appear restless, anxious from pulmonary congestion and low O2. You may also hear rowels, and there may be decreased oxygen saturation. JVD, generalized edema, and hepatomegaly may be evident with right failure. So the nursing care involves medications, an ACE, a beta blocker, an ARB, and possibly DIG. Assure that core measures are done. Lifestyle changes may include a sodium-restricted diet, the importance of taking medications as prescribed. If also on diuretics, they may need a potassium supplement. Balance activity with exercise. They may need to wear anti-embolism stockings. And when to consult the physician for signs and symptoms of dizziness, blurred vision, increased shortness of breath, edema, decreased urine output, and increase in weight gain. The Joint Commission core measures for heart failure is broken up into two components: those that occur during hospitalization and those that should occur at discharge. The EMR should contain information on the ejection fraction. Medications to be included on the EMR are ACE, beta blockers, ARBs, and possibly DIG. Lifestyle teaching should include recommendations for a sodium-restricted diet, the importance of taking medications as prescribed, balance activity with exercise. They may need to wear anti-embolism stockings, and to consult the physician if symptoms of dizziness, blurred vision, increased shortness of breath, edema, decreased urine output, and increase in weight gain occurs. This sheet is in the back of the Living with Heart Failure book. Acute coronary syndrome includes AMI and unstable angina. It's the leading cause of all cardiovascular deaths in the U.S. Some of the lab studies that you may see are X-ray, EKG, and labs including lipids, cardiac markers, CRP, and cardiac cath. Hallmark signs are severe angina unrelieved by rest, position change, or nitrates. Pain can radiate to the left arm, the left jaw, or over the heart. It's more commonly seen in the early morning hours. Other symptoms that you may see are nausea or vomiting, weakness, diaphoresis, cool, clammy, and pale skin. The patient may appear anxious, and there may be arrhythmias. The blood pressure and heart rate will initially be up, then the blood pressure will come down. There may be shortness of breath. Women experience atypical symptoms. Diabetics are more likely to have silent, asymptomatic MIs. Complications include dysrhythmias, heart failure, cardiogenic shock, and pulmonary embolism. These are the Joint Commission core measures for AMI. They're divided up between the acute and at discharge. Why is the angiotensin converting enzyme given? It reduces afterload, which decreases the work of the heart and decreases ventricular remodeling. Remodeling is actual reshaping of the heart muscle in response to injury, such as an MI. Why is a beta blocker given? It decreases mortality by 30%. So what are your responsibilities as the nurse? Your nursing intervention should include the acronym MONA, which stands for morphine, oxygen, nitroglycerin, and aspirin. The core measures include Provide pain relief, nitrile or morphine. Provide oxygen. Patient teaching should include signs and symptoms of angina and MI, the healing process after an MI, identification of risk factors, rationale for tests and treatments, and cardiac rehab instructions. Physiologic monitoring should include INO, vital signs, and heart and lung assessment. Help the patient decrease stress and anxiety. Promote rest and comfort. Because many women do not perceive heart disease as a substantial risk to themselves, they often delay seeking treatment longer than men do, possibly because their symptoms do not follow the well-publicized pattern of heart disease in men. Instead, symptoms may be attributed to anxiety, indigestion, or fatigue. Even after calling 911, women have been noted to experience greater delays in receiving emergency care for cardiac symptoms. The emergency response order set can be used for conditions such as respiratory distress, chest pain, symptomatic hypotension, suspected opioid-related significant respiratory depression, signs and symptoms of allergic or anaphylactic reaction, and suspected symptomatic hypoglycemia or sudden deterioration in a condition of unknown origin. The emergency response orders are found in the admission set. If you're going to use the emergency response order set, please be sure that you call a rapid, as this is a patient who may be deteriorating and will need advanced support. Don't forget to call the MD. This is a screenshot of the emergency response order set. If you need to use them, you go in and open the emergency response order set, adult. Open it and choose the needed items. There is an order for sudden onset of chest pain. This includes a STAT 12-lead EKG with physician interpretation and monitor vital signs and progression of symptoms. There are also orders for acute respiratory distress, which include administration of oxygen 2 liters a minute by nasal cannula, titrate to keep O2 sats greater than 90%, and also a continuous pulse oximetry. If no IV access is already in place, you may insert a peripheral IV. It includes a STAT console to respiratory therapy, an order STAT, a portable chest x-ray, if suspected pneumothorax, hemothorax, or other chest abnormality occurs. These are the primary code team roles and responsibility. Compressions, which is position C, delivers effective compressions with minimal interruptions. Airway management, which is position A, stands at the head of the bed to maintain a patent airway. B, which is breathing, stands to either side of the head of the bed and delivers oxygen via BBM. Position D is defibrillator, safely delivers defibrillation. Emergency meds, position E, is an ALS individual who will administer medications following current guidelines or administer medications following provider orders. The facilitator recorder, position F, facilitates and records the code, ensures all codes are assumed, all rows are assumed, ensures BLS, ACLS guidelines are followed, and needed interventions occur in a timely manner. The facilitator completes all necessary paperwork, ensuring EKG strips are obtained and copies of the code record are sent to the appropriate destinations. The facilitator facilitates a debriefing at the completion of the code. The primary nurse remains in the room and available to provide information and support to the code team. The primary nurse gives report upon transfer and ensures the attending physician is notified regarding the patient's status. In summary, the respiratory system facilitates gas exchange of O2 and CO2 and is complemented by the cardiovascular system, which transports oxygenated blood to tissues and removes waste products. This becomes the driver of the human body. Current assessment related to the cardiopulmonary system helps establish a baseline for patient care and emergency interventions. Core measures associated with cardiopulmonary conditions help to standardize and improve outcomes. Cardiovascular disease is still the leading cause of death for all American women, regardless of ethnicity. Challenges remain for recognition of cardiovascular risk among women of racial and ethnic minorities.